Hello. Hello, hello, hello. It is 11:30 on Saturday, and as promised, I'm here to talk to you about our obstetrics topic of the day. And I chose to talk about pregnancy or fertility in the later years. And by later years, generally we're talking about mid-30s and above. So I'm going to give a few minutes for a few people to join in so we can talk. I see some people already on here. Hi, Emma. Hi, for sure. Hey, tomorrow, music for your quarantine feet. Yes, I will be there. I'll give a few more minutes for a few more people to join, and then I'll start our talk for the day. I hope you're all having a wonderful weekend. The weather's pretty nice here in Greensboro. I hope to go out eventually and get to enjoy some of the sun. I didn't get much of it all week long. It was a busy week. I'll give it another minute and then I'll go ahead and get started. I do have to say thank you to all the people who either joined live last week or shared the video or viewed it later. I was really touched by how many of you watched and how many reached out, and I hope I was able to answer all your questions appropriately. I do still need to give a little disclaimer. I'm not here to give specific medical information to anybody individually through this medium. I want to just share the information so that you know it, and hopefully it just sparks a discussion between you and your OBGYN. If you happen to be near my vicinity, which is Greensboro, North Carolina, and you want to come see me so that we can discuss your specific issues further, I'm more than happy to. But I don't want people to share their personal issues specifically on this platform. I still want to protect some privacy for you. So, all right. Hi, Mommy Kay. And that's the other thing I have to say thank you to all the people joining. I've been touched from the different locations everybody's joining from. A lot of my talks will be focused on statistics based in the US since I do practice here. I do hope to get more details and data from some of the other places that you are so that we can have even more conversations about this. So, hi Randy. Okay, so I'll go ahead and get started, and I'm sure more people will join in later. So for those of you who don't know me, I'll go ahead and introduce myself. I am Dr. Banga, your board-certified OBGYN. I am here really to help demystify the female body for all women of all ages and the men who love them. So that you can make some more informed choices about your health, that of your daughters, that of your sisters, your mothers, all the females in your life. And by doing so, I hope that you feel a little more empowered when it comes to the decision making. So last week I talked to you about fibroids, this week, which was a gynecologic topic. This week I want to talk to you about an obstetrics topic. And as I said before, we're going to talk about pregnancy and some of the considerations for fertility and pregnancy in the later years. So an interesting detail is the point at which most women are born with the most eggs they're ever going to have is when they are still in their mother's wombs. At 20 weeks gestation, where we have the most eggs we're ever going to have. And that is somewhere in the vicinity of 6 to 7 million eggs. Starting from that point on, our eggs start to decrease pretty exponentially. So by the time a female is born, her eggs have decreased from 6 to 7 million when she was 20 weeks old to about 1 to 2 million at the time of birth. And it continues to decrease, as we go through life. Here in the United States, the average age of menopause is 51. So by age 51, the average number of eggs that a woman has is somewhere around 1,000. And in between, when we're born, when we're 1 to 2 million, to 51, when it's at 1,000, you can see how that decrease goes on. By the time we go through puberty, we're usually somewhere around 300 to 500,000 eggs. Most women are waiting a little longer to have children for various reasons: work, life, finances, finding the right partner, and then of course health issues. So I would say on average, I'm finding a lot of women in their 30s sometimes having their babies, and by age 35 we're down to about 25,000 eggs. So this is also disclaimed by saying this is not to fearmonger. This is just to give the facts. These are just numbers that are facts, okay? We all know people who have had babies at later ages, and I'm not here to promote having children at incredibly early ages either. These are just the facts. So we do have to consider our egg quantity and quality as we start to think about planning our future children. How we want to space them out, how many we want to have, should be something to consider. So yes, our eggs are a very important thing. The quality of the eggs also starts to get affected as we go through life. Starting from about age 32, we know that the quality of the egg starts to decrease a little bit exponentially. Prior to that, our ability to get pregnant kind of rises on an exponential curve going upwards. But starting around age 32, it starts to decrease slightly, and by 37, it starts to actually drop. And then, of course, in the 40s, it drops a little lower. So we typically use the average age of 35 as what we popularly call advanced maternal age. I don't like that term, but it is what it is. Advanced maternal age is averagely about age 35. And that has to do with a combination of the quality of the eggs and the quantity of the eggs that we have. Now, men are not completely out of the loop on this. There are statistics that show that the quality of the sperm that men produce also starts to decrease somewhere in their 40s to the 50s. Not as significantly as a woman, but and they don't have the burden of carrying a baby and all of that goes along with it. But the quality can be affected. The quality of the sperm can be affected starting around the 40s to the 50s. There's not a lot of interventions that we can do really for men. Or if there are, maybe I don't know. I'm an OBGYN. I take care of women. So if anybody has any data on that, I'd love to talk about that. All right. So we've talked about considerations of the quality of our egg on the quantity, and how that can impact our decision on when we want to start having children, how many we want to have. There are a lot of other things that go along with age as we go along. Most of us remember having a lot more energy and being more active and maybe a little smaller framed when we were in our younger years. So as the years progress, things like weight, things like high blood pressure, things like diabetes, thyroid disease, those are all factors that sometimes come to play as we age, or actually manifest as we age if they're because of genetic reasons. So a woman's health status really plays an important role in her ability to get pregnant and to have children. Hi, Akos. Hi, Elena. Okay. Hi, Busola. All right. So those are other things that we need to consider, especially if we're considering having children at later ages. Making sure that we're eating well, that we're exercising, that we are maintaining a BMI that is in a semi or normal range. Too low of a BMI can affect the quality of your eggs. So I'm not proposing that everybody be super skinny, because that can adversely affect you in terms of how you ovulate and having babies that are too small as well, which is not necessarily a good thing. And of course, a higher BMI can also do that. So if you're considering having a pregnancy in the later years, you can go ahead and see your OBGYN or your primary care doctor and consider getting screened for some of these conditions. Especially if you have fluctuations in your weight, thyroid disease is an important one, simply because it's been found to be a factor in miscarriage, early miscarriages and pregnancy losses. And if you have thyroid disease, there's such a simple way to manage it. There are medications we can put you on. We can screen you all through the pregnancy. So it's a pretty preventable medical condition. I shouldn't say pretty preventable. It is a medical condition that is pretty easy to manage in pregnancy if we can diagnose it appropriately. Same for diabetes. Trying to get your blood glucose levels down to a better range would help. Otherwise, there are medications we can put you on that can help all through the pregnancy as well. And we can screen you early at the beginning of the pregnancy. We can screen you early in the second trimester. We can put you on insulin. We can put you on oral medications. We can monitor the baby for the baby's size and weight so that we can make the right decisions as to how far the pregnancy should go and how to deliver you. Same with high blood pressure. High blood pressure is unfortunately a little disproportionate in how it affects a lot of women. Unfortunately, women of color tend to have more adverse effects, specifically with high blood pressure, either because it's not diagnosed appropriately, it's not managed appropriately, and the consequential sequelae that can develop from that can be pretty detrimental. Chronic hypertension that is controlled has wonderful outcomes. But if it's not controlled, it can have effects on your liver, on your kidneys, on your heart. And these are all things that can worsen all through the course of a pregnancy. So it's important to get screened for all of these as you start to contemplate getting pregnant. So last week we talked about fibroids. Fibroids, as we know, are pretty slow-growing tumors, but over time and over age, if you have them, they can start to get bigger. So if you're waiting until a later age to have a baby, you could have a fibroid that started out really small and ends up pretty decent sized in your mid to late 30s and going forward, and that can sometimes affect the structure of the uterus, affect implantation, affect the pregnancy, pain, discomfort, all of that during the pregnancy. Endometriosis is another condition that can be diagnosed pretty early, sometimes in your teens, but a lot of times it's misdiagnosed, and unfortunately by the time it gets to when you're ready to have a child, it's caused either scarring or ovulation issues or pain or discomfort, things like that that can affect the pregnancy. I see more people joining in. Hi everyone. Hi Sharon. Hi Amy. Hi Priscilla. Hi Kwame. All right. So let's see what other conditions can develop. We have some genetic conditions like early menopause. Like I said at the beginning, the average age for menopause in the United States is 51. There are some genetic conditions that can cause some people to go into menopause a little earlier. So if unfortunately you are one of those, you could have menopause developing as early as in your early 40s. And the effect of that on ovulation, on your ability to get pregnant, can also, of course, affect your fertility. And menopause is going to be our topic for next week. I've gotten a lot of questions about menopause and a lot of interest in that. So I hope to be able to deliver and answer all your questions. If you guys have specific questions about menopause that you want me to address, go ahead and email those to me so I make sure that I address those. So let's see. Smoking, we know, affects the quality of our eggs. So those are some adverse behaviors that we can try to eliminate. I don't find a lot of women that I see who smoke cigarettes per se, but marijuana use, especially with the advent of all the CBD products, we don't have a lot of data. specifically about it. The little bit that we do have does raise some questions about the effects of it, both on fertility and on pregnancy. So it is something that I do encourage people not to engage in if you are considering having a baby, especially in your later years, given all the other conditions that can be going on. So let's see. One of the things that can also affect pregnancy in later ages is there's a higher risk of stillbirths and miscarriages. Younger than age 35, the average miscarriage rate is somewhere around 13%. But once you start getting into your early 40s, it can go as high as 40%. Or I'm sorry, 20 to 40%. So not only are there some things that can affect the quality of your eggs, the quantity of your eggs can be affected, your health status can be affected. But once you actually get pregnant, unfortunately, there are other factors that can affect the fetus developing appropriately. So the importance of early prenatal care, the importance of things like taking your prenatal vitamins before getting pregnant, making sure that you're taking extra folic acid. Most prenatal vitamins have 400 micrograms of folic acid in them. But when you are over age 35, we recommend that you have at least 4 milligrams of folic acid in it. Now, I don't recommend that you double up on your prenatal vitamins because you can get extra vitamins that are not necessarily beneficial, specifically vitamin A. Vitamin A can be detrimental to the developing baby if you have too much of it. So don't take multiple prenatal vitamins. Take your one prenatal vitamin and then take an extra supplement of folic acid. Folic acid is known to help in the development of the spinal column, brain development, things like that. And women over the age of 35 actually need more of that. So in the prenatal care, making sure that you're taking your prenatal vitamins, making sure that you're taking your extra folic acid, making sure that your health status has been evaluated and any things that need to be worked on are being looked at, making sure that you're talking to your partners about your hopes and plans for fertility and how many children you want to have so you guys can plan them out. The reason why all these matter is, it's making right decisions that'll help with maintaining a healthy pregnancy. Once you get pregnant, like I said, the risk of the stillbirths goes up, but there are also other things to consider. Given your age, there are genetic considerations with the developing fetus. There are structural issues with the developing fetus. So again, this all goes back to good prenatal care. Make sure you talk to your doctors about your concerns, about your family history. If there's a family history of any particular conditions that are genetic, some of these can be screened for. Things like sickle cell disease, cystic fibrosis, other conditions that are a little more probably alien to some people, things like Turner syndrome, Klinefelter syndrome. These are sex-linked chromosomal abnormalities that manifest in different ways. Sometimes they're structural things that you can see to make the diagnosis, and sometimes there are organic things like heart conditions, abdominal conditions, things like that we can screen for. So if you know about any of these conditions in your family, bringing them up to your OBGYN will help target some of the screening that we can do. We can do screening as early as 10 weeks. There are blood tests we can do as early as 10 weeks to screen for chromosomal abnormalities, to screen for genetic conditions. And a lot of the screening tests are controversial to some people. Some people say, I don't want to do anything because it doesn't matter. I'm going to keep my baby anyway. We don't recommend screening tests because we want you to not keep your baby. Screening tests can help you make decisions that have to do with the right antenatal care when it comes to where you should deliver your baby. If we diagnose a condition that could need some interventions at delivery. For example, if we do screening and we find that you have a baby who has a heart condition and you're in a small town with, not a lot of specialists there, we might be able to make a recommendation during the course of your delivery to transfer you to a center that has more specialists there, so that right at delivery, your baby has the greatest success chances for life. So there's that consideration. Sometimes it's about just getting you resources so you're mentally prepared, and getting you into support groups for people who have the same kind of conditions that your baby is, your baby has been screened to possibly have, rather than being surprised with it at delivery. So genetic testing, chromosomal testing, ultrasounds during your prenatal care will really help to make a lot of those decisions. Sometimes there are conditions where, for example, the baby's bowel is outside of the body. Well, do we want to really deliver that baby by a vaginal delivery, or do we want to deliver by a C-section? If we don't do some of these screenings, we're not able to make these diagnoses that can help. And again, unfortunately, in the later years, we do find that some of these conditions are more prevalent in our moms. So once we've gone through your pre-pregnancy screening, making sure that you've talked to your doctors, making sure you're eating healthy, all your health conditions have been addressed, making sure that during the course of your pregnancy you've gotten some of the testing that is necessary to screen for any conditions in your baby. We now have to talk about the actual pregnancy and delivery aspect. Physically, it can be a little more difficult if you're in your later years than in your earlier years when you're pregnant. So this goes back to some of the exercise and things like that have to go along. But you also have to be very realistic with yourself, realistic with your family as to the help that you need. We do find, unfortunately, sometimes that in pregnancy, women are at higher risk for both verbal and physical abuse if they're not in healthy relationships to start off with. So making sure that you have a good core support system just in case you find yourself in that condition, because at a later year, that's the last thing you want to deal with. But when it comes to the actual delivery process as well, having the stamina to be able to push the baby out can be a little bit of a challenge if you're not in the best underlying health condition. And making sure that you have a good support person that's there with you in the room, making sure that when you go home afterwards, you have people that'll help you out, making sure that you have realistic plans in place with your employer as to how much time you really need to take off. Those all come into play. The advantage of having a baby at a later age is a lot of people have careers, a lot of people have the finances to be able to put certain things in place to help them out. So there are advantages to be able to have a baby at a later year. Just make sure that you utilize those resources. There's one thing that I forgot to mention earlier when it comes to the prenatal care. Talking to your doctor about any supplements that you're on, especially herbal supplements, because some of those do have beneficial effects, but there are some that have some concerning effects as well. So making sure that you talk to your OBGYN about that will also help. Making sure that if you're on any medications that have potentially adverse effects on the baby, sometimes some of those medications can be switched out to medications that are a little safer. So for example, I do find that a lot of my older patients sometimes will suffer from anxiety or depression, either leading from situations specific to their fertility, family members asking them, when are you going to have a baby? How come you haven't had a baby yet? Those kind of things. And some of these things do have detrimental effects on women, and they may find themselves needing some medications to help manage some of these. It's fine. There are a lot of safe medications for anxiety and depression during pregnancy. But talk to your doctor about them before if you are already on them, so that we can make sure that you're on the right dose, on the lowest dose of the right medication, really, to help during the pregnancy. Let's see. I see more people joining, and I'll give just a brief recap of what I've talked about so far and where we are. And I'll go through and see if anybody has already posted any questions. So our talk today, again, has to do with pregnancy in the later years, and just encompassing some of the statistical and physical considerations that we need to have when we're considering pregnancy in the later years. So we talked about the quality and quantity of our eggs. We talked about genetic and chromosomal conditions that can affect the baby in the early trimesters. We talked about the risk of stillbirth and miscarriages, especially when you have underlying conditions like diabetes, high blood pressure, thyroid disease. We talked about the importance of physical and dietary wellness. We talked about the need for prenatal supplements and extra folic acid for women over the age of 35. We talked about the effect of men as well when it comes to some of these chromosomal abnormalities. And then now we're talking about stamina during the pregnancy years and postpartum as well. The reason, again, why we're talking about all of this is to help you make informed decisions about the number of children you want to have, how you want to space them out, knowing information that'll help with where you need to deliver, how you need to deliver, and maybe getting you a little better prepared for once the baby gets here. There are unfortunately going to be those instances where you've gotten pregnant, you're excited about the pregnancy, and unfortunately we do find some of these conditions that may not be sustainable for a full quality of life for babies. It's important to be able to have that conversation about if you want to proceed with the pregnancy, or if you want to put comfort measures in place once the baby's delivered. These are conversations that I tend to have, unfortunately, with some of my older patients who have really wanted a baby very much, but unfortunately find that they have some genetic abnormality that precludes the baby from having a good life. And that's a topic for probably another day. It's a very painful topic all around, but it is something that you need to be aware of as you're planning your pregnancy in your later years, as a real consideration that your baby may end up with a condition that might not be favorable. Some statistics to go with that a little bit. Some of the tests that we run in the first trimester for babies have to do with chromosomal or genetic abnormalities. Like I said, one of the most common genetic chromosomal abnormality is Down syndrome. Now, Down syndrome has come years from what it was before. It used to be almost like a death sentence, and it's not anymore. People live to a lifespan of, age 60 on the average, and there's various degrees of severity of Down syndrome. So there are people that are completely functional, full jobs, lives, marriage, children of their own, and everything. And then there are some that are a little more severe because it can be associated with some cardiac defects, some gastrointestinal defects, so GI system defects, things like that. I'll use that just as my example because it's one of the most common. Statistically, around age 25 or so, your risk of having a baby with Down syndrome is probably 1 out of 1,300. When you fast forward to age 35, the risk of having a baby with Down syndrome is somewhere around 1 out of 350. So it's a real consideration. And that's just Down syndrome. There are other chromosomal abnormalities. There's Edwards syndrome, Patel syndrome. I won't get into the details of all of that so much, but with some of these ones, same age, 25, the risk is probably 1 out of 400 to 500. So 475 is what's usually stated. 1 out of 475 people will have a risk of other chromosomal abnormalities. Fast forward to age 35, and the risk it drops to 1 out of just under 200, 1 out of 170. If you go a little further into the low 50s, because I know that we do know some people that sometimes have babies later, that risk goes down to 1 out of 60. So coming from Ghana, I know the importance of religion in a lot of people's lives. And I frequently will hear people say, well, so and so prayed to God and had a baby at this age and that age. And that's amazing and wonderful. I've had patients who've had babies at later ages and everything is done well. But I do want you to also just have these statistics and these facts at your fingertips, just so that you know what the risks are, so that, I pray that this doesn't happen to anybody, but if it does, that you're equipped and you're ready to have these conversations about what you want to do about it. Hi, Shirley. Hi, Kokui. Oh, wow. Hi, Nicolina. Hi, everyone. Okay, I'm going to scroll through and see if anyone has any questions about any of these. For those of you who are just joining, like I said, a lot of my numbers that I quote are based on U.S. statistics. One of the things that I hope to do is to be able to incorporate more data from all over as I go through this process of sharing information with you and also getting data from you, what your experiences have been, not personal experiences. You don't want to share that on a public platform, but you can share that with me privately, and I can incorporate that into my knowledge and understanding as well. So let's see here. Let me go back and see if there are any questions here. Hello, 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 everyone. All right, everybody seems interested in mostly just liking and wanting. Okay, here we go. Ramat, are the risks high if you do IVF with a surrogate? Is it the egg or the womb? Excellent question. Okay, so it's the egg. That's the short answer. It's the egg. So I mentioned earlier that the sperm has also been found to have some statistic risk factors. We know that as people age, sometimes they don't have sex as often as they did in their younger years. Again, and that's not a general. There's some people who are having more in their later years than at earlier ages, but on average. So that has been an important question. Are people not getting pregnant as often in their later years because, number one, there's a sperm factor, number two, they're not having sex as often? Is it just all these extraneous things that are surrounding that? There was actually a study that was done that looked at IVF patients of the same general age who underwent IVF with their own eggs, so meaning at their age, versus using eggs from surrogates who are younger than them. And overall, the people who had pregnancies with eggs from people younger than them had fertility rates that were the same as people younger than them. So it's the egg, not the womb, is the short answer. So if you are older, one of the things you can consider is using eggs from someone younger than you. And you could still carry the baby yourself if you're physically able to. And your chances of having a baby with chromosomal abnormalities would actually be less. So I hope that answered that. Let's see. Hi. I see all the questions. Ramat, I hope that answered your question as well. So there it is in a nutshell. There are considerations for fertility at later ages that are a little different than at earlier ages. It is not all doom and gloom, though. I am the product of a mother who spontaneously had me at a later age. My mother turned 41 the day after she had me. And regardless of what my sisters say when they want to win an argument, I turned out okay. Okay, so hi, Ego and Chewy. But there are those people who are able to spontaneously have pregnancies at later ages. Still those considerations to have. still those conversations to have with both your doctor and your surrounding support people as to if you did have a baby that had any conditions, how they would be able to support you. So I see this. I don't have eggs and unable to carry. I do see that, and I sympathize and empathize with you. However, it's not the end of the world. You could still, there's always the option of adoption. There's always the option of having your husband or your partner's sperm with a surrogate. There's always those options as well. So don't give up hope. I probably need to do a talk maybe later on alternative ways of having a baby. We have some excellent work being done by a lot of our reproductive endocrinology fellows, and I'm actually going to reach out to you personally, but yes, there are options for you having children. They may not necessarily biologically be yours, but if you have family members who share the same DNA as you and they would be willing to donate an egg, for example, those are some very interesting conversations that you can have with them as to how they can support you as well. So, okay, you just triggered me. I'm going to go ahead and have to plan a talk on alternative ways of having a baby. Okay? All right, let's see. What else is here? Let's see. I see. Hi, Nicolina. Hi, Mel. Hi, Ramad. All right. What can I do? So freezing eggs earlier is best. Is there an age when not helpful to freeze? Okay, so I always like to do my short answer and my long answer. Short answer, yes, you are right. Freezing eggs earlier is best. I probably need to read a little bit more about exactly when it's not beneficial. I would imagine that freezing your eggs past age 35 might not necessarily have the best outcomes, because there's not only the consideration of freezing the eggs and making sure that they are of good quality to freeze, but also the thawing process can be harsh on the eggs. It's actually sometimes a little better to freeze embryos rather than just eggs if you're going to do that, especially at later ages, because embryos, and an embryo is an egg and a sperm have been put together and formed a little budding baby, a little budding fetus. So if you freeze those and you thaw them, you usually have better success than if you freeze just the egg alone. So I would imagine it would probably be in your, at least from 35 above, it probably is not the best idea. Or you may not get the most success out of it. We talked about the quality of the eggs going down starting around age 32. So if you want to be really conservative, I would say probably starting in the early 30s, you probably don't get as much success out of it. Let's see. My sister has done IVF 3 times, but it all failed. What should she do? So again, in those kind of specific instances, it would be hard for me to tell you exactly what she needs to do, because there are details surrounding that I don't know. I don't know what her health status is, what medications were used, what the conditions were, where this was. Was this in Europe? Was this in Ghana? Was this in Europe? Was this in Africa? Was this in the US? So there are a lot of specific instances there that we may need to talk about a little further. I can get you some resources that can help. So if you want to inbox me that, I can probably try and get you some resources for that. I'll get you in touch with some specialists that would be able to help with that. My sister-in-law is on IVF. Let's see. The tube is blocked and has lots of fibroids. Maybe sharing this link, maybe. All right. So this question has to do with a tube being blocked. So tubes being blocked can actually happen at any age. It is also higher incidence of that happening at later ages. So that could be a condition of the fact that it could be a result of the fact that she may be having a pregnancy at a later age. Generally, and again, I can't say specifically for the person you're talking about, but generally, if there's a condition with the tube, it could be because the tube is blocked, so the egg and the sperm can't come and meet in the tube. Or it could be that the tube has infection, inflammation, fluid filled in it so that it washes away the egg and the sperm whenever they're trying to meet. A lot of the infertility doctors will sometimes recommend taking out the tubes and then doing IVF. And I'm sorry, I didn't see if you said she has already tried IVF. But again, if she's tried IVF and that hasn't worked, there's still those options of surrogacy, of finding somebody. And surrogacy means that you find somebody that carries the baby for you. Because if your tubes don't work, but your ovaries are making good quality eggs, you can take an egg from the ovary, sperm from your partner, put them together, and then just have someone else carry them for you. I guess some of these conversations will have to do with what your definition of having a child is. Is it that you want to carry the baby yourself, birth the baby yourself? Or is it that you want an infant that has your DNA in that infant? Just your DNA, your partner's DNA, you and your partner's DNA? Or do you want an infant that you can love, regardless of the DNA status of the baby? An infant that you can love, raise, bring up, offer a good life to. So then the conversation about adoption also comes in. So there are a lot of different considerations when it comes to that particular conversation of blocked tubes, IVF, all of that. So I think that's a little more intricate, and I may need to put that off for another conversation. Like I said, I think a lot of you have triggered enough conversations in me to where I promised a menopause lecture next week. So I'm doing a GYN lecture on menopause next week. And I'll have to go ahead and have a conversation about alternate ways of having children the week after that. Okay. All right. So I think that was it with the questions. I hope you guys got some benefit from this. Some numbers, some statistics, some facts, some considerations to have. The importance of why we want to do testing as to, information and knowledge and where to have your baby, the specialists you might need to be there. And as we can see from some of these later considerations, once you're having difficulty having a baby, what options there are for that, which it seems like I need to expand on a little further. So I will. And hope at the end, me here, product of a 41-year, well, she turned 41 the day after she had me. So, it's not impossible to have a child in your later years spontaneously. It's not, and they turn out somewhat decent, I think. I have a sense of humor and everything. But there are some real conversations that need to be had. And I encourage you to talk to your OBGYNs, talk to your family about them. And I will definitely bring you more information. And I'll try to see if I can incorporate more international data on resources when I do the talk next time. So thank you all for watching. I hope you did get some benefit from this. Like I said, once again, for those of you who don't know who I am Dr. Banga, your board certified osteopathically trained OBGYN. I am located in the United States in Greensboro, North Carolina. My mission for doing this is to just demystify the female body and the conditions that surround some of the things we go through for you, for the people who love you, and for you to be able to explain these a little better to your children when the time is right. I can be found on all social media under the handle Dr. Banga OBGYN. So Dr. Dr. Banga, Banga, OBGYN. I'm on Facebook and I do these lives every Saturday. I'm trying to do them at 11:30 every week, if that seems to work for everyone. And I mean, not every week, every Saturday, if that works for everyone. And I can also be found on Instagram, on TikTok, on YouTube, on LinkedIn, and on Pinterest. And I'll be uploading these videos too. So thank you very much for watching, and I hope you all have a wonderful day. Take care.